Hi, my name is Abed Dandashi. I'm a clinical nurse educator. I was graduated in Lebanon on 2003. Our topic today is about assessment and device selection for a vascular access. First, we will talk about some definition of the terms. Then we will go for the IV accesses and the other access. What does it mean, cannula? A cannula, it's a hollow tube made of silastic, rubber, plastic, metal, or other substances used for accessing the body, and we can insert it in any vein in the patient body. Central vascular access device. It is a catheter inserted into a centrally located vein with the tip residing in the vena cava, permits intermittent or continuous infusion and or access into the venous system. Hypertonic solutions, a solution of higher osmotic concentration than that of a reference solution or of an isotonic solution. Hypotonic solution, it is a solution for lower osmotic concentration than that of a reference solution or of an isotonic solution. Implanting port, a catheter surgically placed into a vessel or body cavity and attached to a reservoir located under the skin. Parenteral, a substance administered by any route other than the alimentary canal, such as intravenous, subcutaneous, or intramuscular route. Osmolality, the characteristic of a solution determined by the concentration of the dissolved substance per unit or solvent, measured in millimeter per kilogram. This value can be calculated using sodium chloride equivalent or determined experimentally or by osmometry. The pH, what's pH? The degree of acidity or alkalinity of a substance. This value denotes the number of hydrogen ions present in the solution. Irritant, the irritant is an agent which can cause aching, tightness, and phlebitis at the infection site or along the vein, with or without inflammatory reaction like the dopamine. Vesicant, it's an agent capable of causing tissue necrosis when it escapes from the intended vascular pathway into surrounding tissue like the chemotherapy. Background context, approximately 150 million intravenous catheters are purchased annually. Over 5 million central venous catheters are inserted annually. Complications occur in approximately 10 to 25% of all clients with a vascular access device. 52% of reported complications are directly related to practitioner knowledge or technique. Client morbidity, it's at least 10%. Client and their families currently play a monitor role in the selection of a vascular access device at the onset of treatment. Assessment and device selection. Before we use the device to the patient, we have to select a good device, and we have some recommendation for all of you to look at it before you select your device. Recommendation number 1. All clients requiring vascular access, regardless of duration of the therapy, require the use of a structured approach such as an algorithm to facilitate a comprehensive client assessment and the development of a vascular access care plan prior to the initiation of the therapy. Recommendation number 2. To determine the most appropriate type of vascular access device, the nurse needs to consider the following factors: the prescribed therapy, duration of the therapy, physical assessment, client health history, support system resources, device availability, and the client preference. Now we will talk about it one by one. Prescribed therapy. The prescribed therapy considers the type of therapy, which may include infusions like nutrition solution, vesicant, or irritant, and frequency of the blood sampling. Once the type of fluid is identified, the osmolality of the pH of the solution needs to be determined. The incidence of phlebitis increases as pH and osmolarity of the intravenous solution differs from that of the blood. Duration of therapy. Multiple factors contributed of the development of phlebitis, including cannula material, length of the bore size, skill of the healthcare providing inserting the cannula, anatomic site of the cannulation, the duration of cannulation, the character of the infusate, client factor like the age, race, gender, and the presence of underlying disease. The risk of phlebitis was approximately 30% by day 2 and 39 to 49% by day 3. Physical assessment. Through the physical assessment examination, the nurse should assess the following: circulatory status, impaired circulation, lymphedema and post-operative swelling, vascular status, the mobility of the patient, if he is using crutches, walker, or other transfer aids, mentation, level of cooperation and the mental status, integrity of skin, loss of connective tissue, trauma, open wounds, surgical or radiation damage, activity level, lifestyle factors that may impact on device selection and maintenance, obesity, if the patient is obese, so it is very difficult to find the vein of the patient, hydration status, the dehydration resulting in poor venous filling. Also, if the patient is having a hydration, we will also find some difficulty to find the vein. Client health history. A comprehensive client history related to vascular access may include the age of the patient. Older patient may experience diminished renal function and cardiovascular changes, medical diagnosis and current medical condition like medication profile, including over-the-counter drugs and use of the herbal supplement, current coagulation status, past medical history, including complications of diabetes if applicable, previous history of infusion therapy, peripheral or central devices therapies and outcome, lifestyle, language, cultural barriers, history of intravenous drug use, medical and surgical history like diabetes, mastectomy, renal dialysis, and MRSA positive, allergies and prognosis. We don't forget that some patients, the patients who have post-mastectomy on the right or on the left side, we are not allowed to insert for them the IV cannula in the site of the surgery. Support team and resources. Infusion therapy care may be provided to individuals of all ages with a wide variety of diagnoses and within care settings that may include the home, long-term care, acute care, the workplace, and other locations. The device selection process should be given to the individual support system and resources, including home support resources like the caregiver availability, ability of the client and the family to care for the device and administer the infusion therapy, if needed, a discharge from the hospital. Psychological aspect of care, community resources, financial resources, aspect of the home environment like availability of a sanitary water supply, electricity and refrigeration, adequate storage space for supplies, and access to a telephone. Now we will just show you some of the IV devices. We have the peripheral, we call it the short IV access, used for anticipated IV therapy not rather than 6 days. Repeated venipuncture may be needed to maintain IV access. Infiltration, phlebitis, or catheter obstruction can interrupt therapy. Dwell time and times of medication that can be given are limited. So we cannot insert this cannula and give the patient blood. We need another device to be used. Peripheral midline. This device should be considered for an IV therapy where more than 3 IV catheter may be needed. Maintain IV access without repeated venipuncture. Requires a large diameter vein such as a basilic vein, upper arm contracture, injury, or other vascular or musculoskeletal condition may prevent successful insertion. Type of medication that can be infused are limited. Peripherally inserted central catheter, recommended for all infusion therapy, may be inserted at the bedside or in radiology under fluoroscopy. Use the maximum sterile barrier during insertion. Low rate of infusion. Upper arm contractures, injury of other vascular or musculoskeletal conditions may prevent successful insertion. Radiographic confirmation of tip location is required prior to be used. So this device, we cannot be inserted on the bedside of the patient. We should send the patient to the radiology under radiographic confirmation to confirm the tip of the location if it is inserted or not. Tunneled central venous catheter, it requires a surgical placement, so the patient should be admitted in the hospital and to go to the operating room to do for him a surgery to insert this central venous catheter. Cuff secures catheter in place and prevent bacteria from migrating into the bloodstream. Use Optium aseptic technique, including a sterile gown, gloves, and a large sterile trap for insertion of the central venous catheter. We have also the central implanting port. Also, it requires a minor surgical procedure for placement and removal. May preserve a client's body image. Medication delivery require injection through skin. Use Optium aseptic technique, including a sterile gown, gloves, and a large sterile drape for the insertion of central venous catheter. And now we have also additional to the access, central percutaneous non-tunneled catheter. It is recommended for a short-term access to a central circulation in critical situations or when peripheral access is inadequate or inappropriate. Not recommended for home care. Use Optimum aseptic technique, including a sterile gown, gloves, and a large sterile drape for the insertion of the central venous catheter. Client education. Before we insert the cannula to the patient, we have to educate him or to inform him that we are going to do this procedure to him. Nurse will discuss the options for vascular access devices with the client and family caregivers. Device selection is a collaborating process between the nurse, client, physician, and other members of the healthcare team. However, the nurse has a role to educate and advocate the clients in relation to the selection of the appropriate devices. Documentation. Nurses will document comprehensive information regarding assessment of infusion therapy and device recommendations. This documentation should include as a minimum assessment completed at the written plan of care developed, client and family caregiver education. Now, we will talk about the education recommendation. The principle of and the practice of infusion therapy should be included in the basic educations of nurses in their core curriculum, be available as continuing education, be provided in orientation to new organization, and be made available through continuing professional development opportunities. Principle and practice of infusion therapy should include principle and practices of vascular access planning, including client assessment and device selection, anatomy and physiology, technology and clinical application, fluid and electrolyte balance, pharmacology, infection control, recognition of specialty population like pediatrics, hematology, geriatrics, and oncology, transfusion therapy, parenteral nutrition, approaches to prevent, detect to minimize complications, and communication and advocacy. Organization. Healthcare organizations should have access to infusion therapy nursing expertise to support optimal vascular access outcomes. Healthcare organization must have quality improvement system in place to monitor client outcome. This should include an interdisciplinary process that will monitor quality indicators related to vascular access and infusion therapy, the provision of timely feedback for improved client outcomes, and systems for reporting and capturing data to support practice improvements. In order to support continuity of client care within and between organizations, all clients with a vascular access device and or their caregiver need to have available comprehensive information about the device, which should include as minimum details of therapy, type of vascular access device including number of lumens, date of insertion, tip location for all central vascular access device, delivery system in use, client education plan, client specific instructions, detail of any complication experienced, and appropriate resource as required. Insertion procedure. Before we insert the cannula, we have to prepare the patient. So patient preparation should include ensure and evaluate the patient and the patient family understanding of the procedure and provide reinforcement, evaluates and reinforce understanding of previously taught information, developmental level, cognitive ability, and anxiety level will determine approach to and effectiveness of teaching. The equipments that we will be needed in inserting the IV cannula are syringe 1, 3, or 5 ml, clean gloves, gauze pad, alcohol pad, tourniquet latex-free, transparent semi-permeable dressing like the Tecaderm, extension tubing with layer lock preferable, adhesive tape, normal saline, shape container, anesthetic agent as if the doctor is requesting. So anesthetic agent per doctor's order, it is optional. Splint for also optional, and we usually use it for the infant and the pedia, and underpad. Procedure preparation. Perform hand hygiene according to infection control protocol. You remember, before we do any procedure to the patient, we have to clean our hand before to enter to their room. Identify the patient using patient identification. You have to ask your patient what about his name. You will want to double check if it is the same information you have. Maybe you enter to the wrong patient. So you identify the patient name first, then you go and proceed. If topical anesthetic is ordered by the physician and no contraindicators, apply it in a timely manner as per manufacturer recommendation. If the doctor or the anesthetist asks us to insert or to give the patient like anesthetist medication, we have to give it before 15 to 20 minutes, so the patient will be not feeling when they are inserting for them the cannula. Place patient in comfortable position. A child may be put on mummy restraint to ensure stability during insertion, or ask a family member to assist with physical restraint. Site selection. Complete vascular assessment and site selection. An appropriate site must be identified before catheter placement. Avoid placing the catheter in an area of flexion, such as the wrist or the band of the antecubital space, which can lead of mechanical phlebitis. Avoid the feet in children or walking age in children older than 10-year-old. Leg veins should be rarely used, if ever to be used, because of the high risk of thromboembolism. Avoid the arm on the side of the mastectomy because of impaired lymphatic flow. Use soft, strained, and bouncy vein. Avoid veins near previously infected area. We have to take some special consideration. Ambulatory patients using crutches or walker need catheter placement above the wrist. Patient with vascular disease or dehydration might have limited venous access. In a patient that had a condition causing poor vasculation return, like mastectomy or stroke, the affected site must be avoided. We don't use the arm or hand that has a patent graft or shunt or for dialysis. Patients receiving anticoagulant therapy have a propensity to bleed. So now, after you place the patient in a good position, First, you have to wear gloves. You apply the tourniquet around the arm 10 to 15 centimeters above the proposed insertion site. So let's say you want to insert the cannula. In this area, you have to apply the tourniquet here. If we want to apply the cannula in this area, you have to apply the tourniquet here in this area. Position the extremity lower than the heart. Instruct the patient to open and close his fist. Tap the vein using the index and the middle finger. We tap the vein on this way just to see the vein clearly. Clean the area using the alcohol pad in an expanding circular motion, middle to outward. We don't use the alcohol pad on this way. Either you around it on this way or up or down. But up and down, it's not allowed. Use non-dominant hand to stabilize the selected vein. If a patient is right-handed, we don't insert for him the cannula in the same hand, in the right hand, and vice versa. If he is left-handed, we don't insert it in the left hand. Apply traction to the site of insertion site with the non-dominant hand. Penetrate the skin to a 10 to 30 degrees angle with the level of the catheter facing up. Advance the catheter into the vein until the hub is in contact with the skin. Release tourniquet as no longer needed. Remove the stylet and discard it in a sharp container to prevent needle stick injury. Attach a T-connector. Attach a flush syringe with the normal saline and perform gentle flushing into the axis into the IV line for potency. Secure all the connection and initiate therapy as prescribed. In the children's stabilized catheter, we can use an arm bore to protect catheter from being dislodged. Put a label with the date, time, and the initial of the person who insert the IV cannula using the supplies and equipment in appropriate container. Remove gloves, perform hand hygiene, and document what you have done. Now, after we insert the IV cannula, we have to, the post-procedure monitor care. We have to monitor the IV cannula of the patient. We have visualized and expect insertion site and extremities where catheter has been placed every 4 hours for adult and every 1 hour for pediatric and neonatal before and after giving any IV medication. Aspect dressing regularly to ensure that it is dry, cleaned, and intact. Change dressing immediately if its integrity has been compromised. All IV tubing, infusion sets, dressing, and insertion should be changed every 72 hours unless indicated to be removed prior to that. If we have a patient with IV cannula, the maximum we can use it is for 72 hours. But if we find that there is any phlebitis, any complication before the 72 hours, we have to remove it immediately and insert another IV cannula. IV bags and bottles should be changed every 24 hours. If the IV are in only heplock and we are not using it, every 8 hours we have to flush it. Inadvertent catheter removal should be reported. Dislodgement or removal of catheter by the patient child should be also reported. Volumetric pump must be used in children with IV therapy. What are the complications that we might face during the IV cannulation for the patients? Phlebitis. What is phlebitis? It's an inflammation of the vein, may be accompanied by pain, erythema, edema, stick formation, and palpable cord rated by a standard scale. Thrombosis. It's a formation, development, or existence of a blood clot within the vascular system. Infiltration. It's an inadvertent administration of a non-vesicant solution or medication into surrounding tissue rated by a standard scale. Extravasation, inadvertent administration of vesicant or irritant solution or medication caused pain, burning on the site.